cloud. I'll go ahead and record to the cloud.
Yeah. I'm getting it on my computer.
Okay.
Have another 5 minutes, I think, right?
Or even, yeah, or even at most.
3 more
Yes.
minutes.
Yeah. Right. So as I said, between now and 4:35 is when most people join. Okay. So, all right. Some of your kids are
Yes,
at your
they are
in-laws?
at my in-laws' place.
Very good. Sorry, today is a free day.
Yes, so they can do what they want.
No, but I admire you for what you do. I mean, holding on to two of them, dealing with their schooling and
No, but
keeping
then
up your professional work.
I mean, I don't think I have a word to say because there must be so many here who've dealt with more than two and done more. So you know, amongst this audience, I'm always humbled. Like, I always get to learn more about how I could do things, you know, in a more organized manner. I still feel that I'm running around like a headless chicken sometimes. I should.
Okay.
I can understand that. My younger son's having a problem getting hold of a teacher a nanny come teacher for the homeschooling.
Huh.
Oh God, he says, oh my God, it's amazing
Tough.
how difficult it is. And one or two who came in, my little granddaughter, a 3-year-old, managed to drive the movie. We all Dennis the Menace.
They just...
I think I've also started my side. Good evening, everyone. Welcome again. One more session of conversations, our Saturday evening ones. And we have with us Dr. Soumya Hegde, who's known to at least some of us and has visited us physically before, but this time she's joining us via Zoom. And I'm going to pass the microphone on to Rama. Rama, please. Rama will be introducing Soumya.
I consider it a privilege to introduce Dr. Soumya Hegde to the audience today. Dr. Soumya graduated from the Grant Medical College, Mumbai, did her psychiatry training from Lokmanya Tilak College, again Mumbai, then on to obtain her MRCP psychiatry from UK and CCT in old age psychiatry. After working for about 8 years in UK, she returned to India with the hope of providing a holistic and
Okay. For others from outside, including Soumya, this has happened to us before. There has a power cut. It takes a few minutes. I happen to continue because I have a UPS on my internet, but for others, it cuts off the internet. So it's kind of a little embarrassing. But
no problem.
Yeah, and Mr. Raja's in Kerala, you know, God's own country where there are no such thing as power cuts. So,
and Bharat, thanks to you, I have a UPS now. So.
Oh, fantastic!
That's lovely.
So I'm not worried about the power cuts. Yeah, so he gave me some advice on what to buy.
Oh, you actually went and bought one in the last 24 hours?
Hard. It was really hard otherwise to manage online classes. It was, you know, because it would take about 10 minutes to reboot each time, by which time, if they have exams online, then it's tough.
Right. So the way we'll know is, I think, when Rama comes back on, because I think she does not have a UPS. So once she comes back on, I'll be able to. And the problem is, it goes the other way too. Is that then the power comes back, and then the DG strips.
I get it. Yeah, it goes back.
Yeah, you'd have the same.
She's back.
On. So I'm going to assume
Oh,
slowly.
has come back. I think that's she.
Yeah, I'm going to ask her to unmute. So this happens with your classes as well. Rama?
Yes.
Rama, so
Sorry about.
right. So I'm going to use you as a proxy. So I'll assume that if you're back on, it means others that are back on. So let's continue. I think in today's times, everybody is used to Zoom meetings being cut off and resumed, and particularly our guest Soumya is quite aware of these things. Go ahead, Rama, please.
Yeah. So she returned from the UK after 8 years with the hope of providing a holistic and quality geriatric mental health service here. An associate director of the Nightingale Center for Aging and Alzheimer's, she has tested and worked with thousands of elderly patients with dementia and other mental illnesses. She specializes in managing challenging behaviors in dementia through a holistic approach. Can you hear me?
Yes,
Hello?
I can.
Yeah, sorry.
Yes.
Okay.
We're doing
So
well.
a holistic approach of medication, supported physiotherapy, individualized care plans, and more important, caregiver training. She believes it is only through creating awareness and improving community support that we can mitigate the sufferings of patients and caregivers. She has played an active role in many awareness and advocacy campaigns. She's currently associated with the Nikisa Dementia Village and Annasamy Mudaliar Hospital at Fraser Town. She also consults at Indiranagar, but of course, at present, it's all online, I understand. I have a special connect with her. My go-to person when life was.
Okay, we seem to be cutting in and out with Rama. Sorry about that. Just the way it goes. Rama, can you hear?
And welcome again.
Okay.
Thank you.
Thank you, Soumya. It's all yours. You have the floor. Thank you.
Thank you, Rama, for that very extensive introduction. Just a little correction, I'm not associated with the Nikesa Dementia Village. I was with them briefly. I'm not anymore.
Okay.
Okay. Yeah, so just clear that. But thank you very much to Athashri. This is my second opportunity to interact with a very vibrant set of seniors in Bangalore. Have very high regard for all the occupants in Athashri, some of whom have over the years, moved on from being caregivers, patients to good friends. And I think I value that relationship a lot. So, Bharat, Rama, and I think there are a few others as well whom, we share a very close relationship with. The topic that Mr. Raja thought that I should talk about was, in terms of mental health and aging. And he said that, let's not focus too much on depression because enough has been said about it. So I have tried to include some of the other conditions which also affect us not that they affect us as we grow older. I mean, I think they affect people across ages, but how do they differ in terms of their symptomatology as we get older? And how does management change as we get older, because we can't apply the same management strategies that we would apply to a 24-year-old for a 55 or 65-year-old. So I'm hoping to, touch upon some of these aspects. But I would love to hear from you and your experiences and any questions. And I think we'll take them at the end, right, Bharat? Or should we take them as we're going along?
It tends to be a little bit more efficient to do that in one time, because otherwise it's just hard to coordinate on Zoom. So yes, let's do it at the end.
But if there's, there's some of them which I've put in some case vignettes. So if anybody would like to, respond on the chat box, I think I can see it too. So that would be good. Okay.
Perfect. Yeah.
So let's start.
And then,
without,
and then we can make on the spot decision. If you want to handle that question, by all means, we'll open it up.
Fine. So can I screen share, Bharat?
Yes, please do.
Am I audible to everybody? And am I speaking at a speed that's okay? Or do you want me to slow down further?
No, I think it's fine.
It's fine?
Yeah.
Okay.
Yeah. And we're getting thumbs up from various people. Okay. So they're muted, so they can't tell you. Okay. Yes.
All right. So that's broadly what we're going to talk about today. So I thought that before we go into the rest of the discussion, let me just, talk about why is aging and mental health a separate category? Why did we even have to separate mental health in a senior population from mental health overall? That's because, as you see from the statistics, by the year 2050, which is just another 30 years, 1 in 5 people will be over the age of 60, which means that we would have to start developing services and start training people to recognize mental health issues in an elderly population and develop, the kind of community support that we need to manage these conditions as people get older. But I like to start with this slide. And I think I've shown you this slide when I was at Athashri before too. I like this slide because it kind of gives you a broader definition of age. So we have first the chronological age, which is quite literally, you calculate it based on the year that you were born and how many years you've actually lived. Then you have the biological age, which is the age by body function. So often you hear that, the doctor tells me that the age of 80, my reports are as good as a 30-year-old, which means that you're biologically not aging. Or you have a 40-year-old who'll tell you that, my blood reports are equivalent to somebody who's 80, or my heart is functioning at the rate at someone who's 80, which means that he is aging much faster for a 40-year-old. So that's our biological age. And then there's the psychological age, which is the age that you feel. So you might be someone who's 80, you might have diabetes and hypertension and a host of other medical problems, which means that your kidney is not functioning as well it should, or your heart isn't, but your mind is full of energy. You don't want to look at any of these things. You feel young. And that's what psychological age is all about. And I think that's the most important kind of age. So no matter what your chronological age, no matter what your biological age, as long as you psychologically don't allow yourself to age, you're fine. Okay, so, and you can see, below on that slide, you've also got these categories. So, some time back, I know my maid would tell me that, ಅವರಿಗೆ ವಯಸ್ಸಾಗಿದೆ in Kannada, she would say, and I would ask her, ಎಷ್ಟು ವಯಸ್ಸಾಗಿದೆ? She would say, 50 ಆಗಿದೆ ಅನ್ಸ್ತದೆ. And I was like, ಅದು ವಯಸ್ಸಾ? So very soon I would be in the senior category too then, if that was the case. So I think, that the definition of age has shifted. It is no longer that, you hit 50 and you should be considered as aged. So we have young old, which is, from the age of 65 to 75. And then you have middle old, which is going up to the age of 85. And only old is beyond the age of 85. Okay, so I'm assuming everybody in my audience today, and majority of them are not old. Okay. So let's move on. So let's talk about mental disorders. Now, you know that, a lot has been spoken about in the media in the
Soumya, I think you accidentally got muted. Can you please unmute?
Okay,
Yes,
I'll
sorry.
unmute. Yeah,
that may have been my doing. I apologize. Please go on.
okay. So, so when we talk about mental health from a mental health professional's point of view, it's very different from what the media and people out in the society project mental health to be. So as you can see, we use these terms in a very colloquial way, and it's just thrown around. Oh, he's being quite a psycho about this. Is she bipolar? You had this whole thing with the Sushant Singh Rajput case, where everybody had an opinion about the condition that he was suffering from and what he should have done and what he should not have done. And it's actually quite sad, because if it was, the jury's still out on this, so I don't want to say anything, but if he did suffer from a diagnosable mental illness, then the last thing we should be doing is speculating, because it is serious and it is something that requires help and support and medication when things are really bad and he was at the stage of being dysfunctional, if he was suffering from bipolar. So it is important that we don't use these terms loosely while referring to people. And if we are not sure, I think it is also important to understand what these terms actually mean. What are the symptoms of these conditions? And how do you identify someone who genuinely suffers from this and get them the right kind of help? Okay. So the next slide. Bharat, why am I not able to move? Am I stuck?
You got me in that one.
Should I go
Yeah,
back?
yeah, or try an escape on your side. I think this is independent of Zoom.
Okay.
Yeah. Now try
Forward.
clicking physically on the next
Yeah,
one.
okay.
There you go.
So I have a small case vignette to start off with our, the first kind of condition. Let me put it that way. So I'd like just give you a couple of minutes to read through that. So there's a 75-year-old female who lives with her husband, complains of feeling low in energy, not interested in anything, sleep disturbances, wakes up at 2 or 3 a.m. and then can't sleep. And this has been happening since 3 months. Through the day, she experiences a lot of restlessness, nausea, occasional bouts of palpitations, sweating, struggles to breathe, and feels that she will collapse. There are no identifiable stressors, no major medical illnesses, or any regular medication that she takes. So, any thoughts? Should she go and seek help?
People are muted, so
Oh, any chatting? Nothing? Okay.
not seeing any. Not seeing any.
Okay.
So let me fill in for the audience. The proxy, I would say it's it's starting as some low-level depression, but it is suggesting greater illnesses downstream.
Okay. Good, Bharat. I've
Well,
taught you well.
well, life taught me well too, because I've seen this up close and personal.
Yes.
Okay.
So you're absolutely right. And the reason I picked this one first is because, this seems to be happening in a lot of people. A vast majority of people living do go through these, and they don't really think that anything can be done about this, and they go through it for a long time. And the condition that we're talking about here is anxiety. So it is a generalized anxiety with the bouts that I was referring to in the case of panic attacks. Okay, so let's move on, and I'll tell you a little bit more about anxiety itself. So what is anxiety? I mean, I think, any of us who is alive and has, lived would know that we have experienced anxiety at some point in our lives, right? I've certainly experienced a lot of anxiety the first day of school, the first day at work, an interview. It's anxiety is our response to anything which is out of the usual for us, something that we haven't done often enough. The first time I had to do a Zoom presentation, there was a lot more anxiety than perhaps today, because I've now used to it. I've done this a lot more, so the anxiety is less. But when I'm doing it for the first time, or when we are faced with a new situation for the first time, we all experience anxiety, and that's normal. Because once the situation passes, if the interview's over or whatever it was, the flight that I had to take, I've landed wherever I had to land and I'm safe, the anxiety passes. We no longer dwell on that and we move on. And it's not caused any kind of dysfunction in our day-to-day lives. But when it is excessive, then it is maladaptive. When I mean by excessive is it takes up almost all your waking hours. It affects various aspects and various things that we do through the day. So you may not be able to focus on an activity that you previously enjoyed. Television programs, people tell me they could sit through a movie, but now they can't. It's just 10 minutes into the movie and they start feeling very restless and edgy, and they've got to get up and start moving. They can't sit. They can't finish their Sudoku puzzles. They can't sleep at night. When they wake up, they're constantly thinking about something, stressing about something, but they can't even put their finger on what it is. A lot of the times, they're not able to clearly identify what it is that is causing them stress. So it is very paralyzing and it's very embarrassing. They're afraid to go out because they feel that what if I have that episode while I'm out there and I can't deal with it? What if I'm stuck in a lift, or I can't deal with it? What if I'm stuck at a traffic jam and I can't open the doors of my car? So it is extremely paralyzing, and the thought of going through that at another point makes them extremely anxious again. So it's a vicious cycle. So the symptoms are broadly categorized into cognitive symptoms, you've got behavioral symptoms and physiological symptoms. So there's again multiple symptoms within each of these categories, but commonly, you'd have cognitive symptoms is a worry or a sense of fear. And again, as I said, a lot of people are not able to clearly identify what are they actually scared of, but they feel it. They feel those butterflies inside their stomach constantly. They're scared. The behavioral symptoms, they start sweating, they're restless, they're actually moving around. They're finding it difficult to breathe. Their respiratory rate is high. They're hyperventilating, palpitations. So they experience this whole gamut of symptoms, either for highly intense periods through the day, or in a kind of a simmering way throughout the day, which does not allow them to function or think of doing anything new. Now, when we see these kind of symptoms in an elderly population, then we got to think about some of these other conditions as well. Okay, so that's why I've put them up separately, although the symptoms may be the same, but as Bharat said earlier, it could mean that it's going on to develop into another condition in the future, which is why we need to evaluate it more thoroughly and make sure we're not missing any of these other conditions. So it could be coupled with depression. It could be dementia in the very early stages, where the person is aware that something's not right, but they don't know what it is. Something's happening to me, but I can't understand what it is. And that's where, they feel extremely restless and anxious. It could be associated with a medical condition. It could be a condition like a thyroid dysfunction. So we need to evaluate the person thoroughly in that regard too. Or it could be comorbid alcohol dependence. So that's another history that we have to take when we're looking at someone with anxiety. Is there anything around, habitual alcohol use? So the interventions are pretty straightforward. So in very mild cases, we don't rush into giving them medication. We try and explain, which is the cognitive therapy bit of managing anxiety. We try and explain to the person why this is happening. Where does it come from? It starts from a dysfunctional thought in the brain, which then leads to all these behavior and physiological manifestations. So it is important to try and, change that thought to a more positive thought each time you feel that. You could try deep breathing. You could allow them to walk, because that does where, that just allow the anxiety to just get out of your system. We also suggest things like having an anxiety time, or specify a time in the day when you allow yourself to feel anxious, allow yourself to dwell on these thoughts, and that might not allow you to be dysfunctional through the whole day. A lot of repetitive activities help with anxiety. So you've got advice from psychologists telling you to do things like Zentangle, the kind of knitting or crochet for those who do it, because it's a very repetitive activity and does help us calm down. Even, you have elderly people writing Sri Ram, Jai Ram, or anything, like a repetitive kind of a writing work also helps us calm down. So anxiety can be tackled in lots of these non-medical ways. But if it's something that is not settling with these interventions, then of course regular appointments with a counselor to work further on those dysfunctional thoughts that are there in the brain, and how do you shift them into a more positive way of thinking. And then if it's still not helping, then we resort to medication. So there are medications which we use for anxiety, and patients benefit, and all of it is just completely cleared. So this is a completely curable condition, which is why it is important to address it and treat it at the earliest.
Soumya?
Yeah.
Can I interrupt with one question that came in from the chat that might be relevant from Tulsi Tiwari? Would you say a person who's a self-learner, like Professor Raja, can actually never have anxiety? That's the question. So the question.
I think I'll let Mr. Raja answer that.
Exactly.
Okay.
I'll do that later.
Okay.
I think towards the end of the presentation, I'm going to talk about certain factors which contribute towards each of us developing these mental health conditions, and how do we try and keep us from developing these conditions. So that's the last part of the presentation. So if I still don't answer the question, then of course Mr. Raja or I will take that.
Okay.
So now this is a new kind of anxiety, which we have seen a lot of in the last 6 months. And that's why I just put a few slides around that, because I've seen a huge increase in anxiety. And I didn't see so much of it in the first 3 months of the lockdown period. But come May, and I started having a lot of patients calling up, or lots of, family members calling up, because they wanted to try and understand how to help someone with this specific type of anxiety, which we can now call as COVID-related anxiety, because there was none of that before. They were completely functional. So the COVID anxiety seems to be stemming from the increased isolation, particularly because the media projects the elderly to be at high risk, and therefore the elders have kept themselves away from a lot of activities that used to keep them busy and engaged previously. Anxiety and the symptoms itself, as we have discussed before, would be present. Fear of fraudsters, because that's the other thing that I have seen is a lot of people wanting to, help, and elders are not really sure how many of these are really genuinely people who want to help, or, so they might be turning away people who could help them out, but because of this fear that they're going to be taken advantage of, or there's some kind of potential harm to them, the anxiety is higher. I'm alone, I'm living in this place alone, people know I'm alone, and therefore I'm more vulnerable. Fear of the unknown. What if something happens to me and my near and dear ones can't reach me? That's a fear that a lot of us are. It's not just, I don't think it's specific to the elderly. I think a lot of us are worried about this. If we are not living with our immediate families, that what if something happens and nobody can travel because of the travel restrictions, and then they come here and then there's all this COVID, or I'm admitted to a COVID ward and I won't be able to see my near and dear ones, and I'll be left at the mercy of the nurses and doctors there, and who knows whether they will understand my needs correctly or not. So there's a lot of fear of this unknown. And what if I die without seeing my near and dear ones? What if I don't come back home? So there's these new fears that are associated with COVID, which we hadn't been seeing previously. So again, the management is not very different. Of course, there's a few extra things that we would add when it's specifically related to COVID is selective listening, particularly if you are someone whose personality is such that you would get quite anxious very soon. Then do not listen to everything that the media has to brandish. Be selective. Don't open all the WhatsApp messages. I mean, thankfully, they are coming down considerably now. I don't seem to be seeing as many of those as I was seeing a couple of months back. But still, if you feel that there's information out there that makes you more anxious, there's data out there which makes you more anxious, then it would be prudent to not open every message, and probably find someone whom you can trust to share the important messages with you, and just put your stuff, your WhatsApp messages on, and don't auto download everything. Create a routine within with the circumstances that we're in right now. So you can't go out for a walk, but what can you still do inside the house? That is certainly going to make a difference in terms of keeping that routine. So yes, I used to get up in the morning, I used to have a bath, and I used to get dressed, and I used to go out, and maybe there was a clubhouse or there was a group of people that I would meet. Try and do as much as you can in terms of maintaining that routine. Maybe you can't physically go and meet people, but you can still connect with them over a video call or these Zoom kind of meetings. So allow the meetings to continue as long as you're not physically coming in contact with them. Role of technology. Now, I think we've all learned quite a bit. I certainly have. And I'm still learning. I'm learning. Even yesterday, Bharat taught me a few things about Zoom, which I didn't know. So I think technology and the role that it has played in our lives is very, very vital. And you wonder what would have happened if we had been struck by COVID 20 years back. I mean, in what way would we have all coped? I mean, because of technology, we're still able to keep in touch with each other. There's so much that we can do. We can work from home. All this would have been impossible if not for technology. So in some sense, we've had, that comfort that we can still do a lot even if we're restricted within our homes. The other one is reach out. Try and connect with people, neighbors. Not everybody is going to stay away from you. Not everybody is going to say, don't come near me because I'm scared of, catching COVID. So reach out. There are organizations which will, get you trusted volunteers who are vetted out. And so you could, rely on that resource. So try and find out people who are there to help you, your neighbors, your friends, and then reach out to more people who can provide you the help and support that you may need. Risk versus benefit. Now, I'm asked this a lot of times. Now, if I have someone who's at home and who's so scared to go out because of COVID, but because they're staying indoors for the last 6 months, it's driving them really, their sleep is affected, they're not able to function, they're not able to see people and talk to them, and it's really affecting their mental health, and they're becoming depressed. I don't think that's the kind of condition in which I would say don't step out. So I think we've got to weigh the risks and benefits, and you can step out. Who's telling you not to step out at all? Step out, wear your mask, make sure that your hands are sanitized, keep a sanitizer with you. Don't go very close to somebody. Please go and buy your groceries in a store when, when the store is not full of people, not on a weekend, maybe mid-afternoon, in the week sometime. But do find ways to go out if that's what keeps you mentally well, because the risk of developing COVID and the risk of succumbing to a mental illness, you've got to weigh which one outweighs the other. And the chances of whether you will get COVID or not, I really don't know, because unless you come in very close proximity to someone who has COVID and you're not wearing your mask, it's unlikely. But the chances that you will probably get a mental illness like depression if you don't step out are probably higher because you're seeking help. So do weigh the risks and benefits and decide for yourself what will be the right thing to do. And if you have doubts, then it's always best to speak to somebody and find out what is advisable and what is absolutely not. And don't hesitate. If medication is recommended, then it is, as I said, it's a curable condition. So try and get yourself treated if medication is recommended by the professionals. So this is something. So so there's a lot of being said about social distancing, but it's not social distancing that we need to protect ourselves. It's just physical distancing. You don't socially need to distance yourself. Just need to wear your masks and keep in touch with everybody that you need to. The next condition that I thought we would speak a little bit about is any guesses? No, they're all everyone's on mute. Rama, I can't hear you. I don't know if you're trying to say something.
No, I think everybody's on.
Okay.
Yeah,
So
the chat hasn't come on. Yeah.
Okay, so it's insomnia. Okay, so insomnia is another condition which we see quite often as we age. A lot of people say that I'm not able to sleep as much. So I thought we'll just touch upon that briefly. So there are many types of insomnia, and if I were to very simply classify them in when we take the history, then we ask if you have difficulty falling asleep, which means that you go to bed at 9:30, 10, but I can't fall asleep till 1 or 2 in the morning. If you have difficulty staying asleep, which means that I fall asleep, but then I keep waking up and I'm not able to sleep through the night. If you have difficulty in terms of you wake up very early, so you sleep from, let's say, 9:30, 10 till about 2 or 3, and then you're up and you can't go back to sleep, but you don't feel rested, so you're not feeling restored by your sleep. So that itself, that all comprises insomnia, and any of that could be something that the person is suffering from, and there are things that we can do to address that. So firstly, let's talk about some of the medical conditions which could be leading to insomnia, which again, as we get older, we are more prone to develop these conditions. So you've got pain. If there is low back pain or arthritic pain, then it is that the pain is keeping you awake at night. So we need to address the pain. If there's cardiac conditions which cause you to be unable to lie down in a supine position, you might keep waking up because you are uncomfortable. If there are GI disorders, like you keep having to go to the toilet, you feel acidity and you're not able to lie down, that could be something that needs to be corrected. People with asthma, angina, urinary symptoms, again very common, frequent visits to the toilet through the night, again these are things that can be corrected. There are medication available to help with these problems, which could then restore sleep automatically because you've taken care of the underlying problem. So insomnia by itself could be as a result of these conditions, which is why it is important to see if any of this is responsible. Again, certain medications. So when we take the history, we always check for how long have you had this problem, and if there have been any medication changes around that time. Some of the medications we take can keep us more awake. Just like you have cold medication, which puts you to sleep, there are some medicines which actually make us more alert, and those medicines are probably not best taken at night. Again, it varies from person to person. So unless you go back and tell your physician that this is what is happening to me, they may not be able to advise you that you could take it at a different time in the day. And that's all the correction that would be required, and your sleep problems would be sorted. So what is the impact of disrupted sleep? And again, as you can see, it's a vicious cycle. I don't sleep for a few nights. I start worrying about going to sleep tonight because I don't know if it's going to be a good night or a bad night. I worry about having to wake up and not knowing what to do in the middle of the night. So it keeps going on, and the stress keeps us awake. And we're not going to fall asleep as long as we're feeling anxious about falling asleep. So it's a paradoxical, but that's what the cycle is. So what are the benefits of a good night's sleep? We all know what are the benefits. You feel more energetic, you're able to do so many different things in the morning. You feel rested and you are able to achieve a lot more. And it's also great for our immune system if we've well rested and we are able to get up in the morning and go for a walk and eat and cook and do everything that's necessary. It's great for our immune system and for our mood. And what are the problems with lack of sleep? Certainly persistent and chronic insomnia of any of those types could lead to hypertension, diabetes, dementia, fatigue, just chronic fatigue because you just haven't had restful sleep for months, causing road accidents because you're not as alert, drastic mood swings, you're more irritable, you just, you're snappy because you're just not rested. You don't feel yourself, and sexual dysfunction also as a result of lack of sleep. So what are a few things that we can do to help us sleep better? Again, I'm looking at the non-medical things that we can do before looking at the medical stuff. Now, I spoke about the medical conditions, which we need to look at to see if any of those is the reason for insomnia. But apart from that, keep a regular bedtime and wake up time. So even if you're suffering from insomnia, and even if it's something where you went to bed at only 2 or 3 in the morning, if 6 o'clock is your waking time, wake up at 6 o'clock. Don't tell yourself that I need to sleep for 5 or 6 hours and therefore I'll wake up at 9 o'clock. Try and sleep in a dark, quiet room. Try and keep yourself warm or cool or whatever it is that makes you comfortable. That's important. Like there are times when you might need to wear a pair of socks to go to sleep because you don't like your feet being cold in the night. So all those can help you sleep better. Clear your head of any worries. I mean, there's lots of things like yoga nidra, deep breathing before you go to sleep. Try and listen to some audiobooks about a very neutral topic. Don't listen to a thriller or suspense thrillers. That doesn't help us go to sleep. Turn off the television and refrain from using any social media for at least an hour before it's bedtime. That is important so that you're not while you're asleep, you're not going to be dwelling on whatever it is that you've read in the last hour before you've gone to sleep. Avoid alcoholic drinks and caffeine very close to bedtime. I mean, avoid alcoholic drinks are normally taken in the evening. So I can't say avoid them completely, but what happens with a lot, or if you excessively drink, then it does disrupt your sleep cycle. You may fall asleep, but you tend to wake up and then you're not going to be able to go back to sleep. That's usually the effect of alcohol on sleep. Caffeine, avoid after 5 o'clock in the evening. Also avoid drinking excessive amounts of water after 5 o'clock in the evening, because then that would result in frequent trips to the toilet in the middle of the night. Regular exercise, a diet, a good healthy diet, which is nutritious and balanced. Don't eat a very heavy meal before you go to bed. And if awake, get out of bed. And that seems to be, one of the big tips in sleep hygiene, that don't make your bed the place where you are anxious about not being able to sleep. So if you are not able to sleep, get out of bed and figure out what you're going to do in the night. Maybe it is, just make yourself a small light snack, find a book to read. And once you start feeling sleepy again, then take yourself back to bed. I also wanted to touch upon some of the sleep medication myths. Now, a lot of people talk about, I don't want to take a tablet to help me sleep. I'll get addicted to this tablet. This is, there's lots of these fears around medication that helps people sleep. So where I see a large number of people who have been taking medication to help them sleep for 30 to 40 years, I also see an equal proportion of people who say, don't give me a sleep medication. It's not a sleep medication, right? So now the thing is, again, it comes to risk and benefit. Now, if you are someone who needs a tablet to help you sleep, and if it's a small dose of one of these tablets, and you are aware that it is a tablet which is only to help you sleep, then in order to correct your sleep cycle, I may need to introduce it. We have lots of options. There are tablets which are more in tune with, trying to set our natural sleep cycle right, like melatonin derived medication. There are tablets which only help you fall asleep, but then allow your natural cycle to continue afterwards. And there are tablets which we prescribe if if the person is particularly anxious and not able to sleep, so that they're not anxious before they sleep. So the anxiety is taken care of, so they fall asleep naturally. So medication is of different types. So it is important that when your doctor prescribes you sleep medication, try and understand what is it that the doctor wants to do by giving you the sleep medication, so you have better control in trying to come off it. So if they say that this is going to help you calm down before you sleep, then you know that you have to work more on non-medical ways of calming down. So you may start the medication so the sleep cycle is set right, but then you try and wake up in the morning, do your exercise, do whatever else is required, tackle the stressors in your life which are making you anxious, look at positive thinking and the cognitive behavior therapies that we talked about with dealing with anxiety, and your sleep cycle would be corrected. Sleep medication in itself is not bad. Sleep medication, when you become dependent on it, like if you start with a 0.25 and then a year later you're on 0.5 and then you go up to a 2 mg tablet, then that's difficult, because then you don't know where else to go after that. If sleep medication has to be initiated when somebody is in their mid 90s, that's not a bad thing, because it's all right. Even if they're on sleep medication for the next 10 years, I'm not worried about it, right? I'm not worried about dependence. All I'm worried about is quality of life. And if I can get them a better quality of life by helping them sleep better, then that's all that matters. So don't just broadly just listen to the media out there and say that sleep medication is bad, we shouldn't be taking it. I think it's important to understand what the medication does to your system, and then take it in you educate yourself and take it in an appropriate manner. Moving on to the next one. So we've talked about anxiety and insomnia. This is the next condition that I wanted to address. Are we good with time? Okay. So there's a 65-year-old who lives with her husband. Children are settled abroad, no medical comorbidities, likes to read and cook, has many friends, but has a 2-year history of slowly dropping her interests, constantly on the phone, checking her Facebook and Insta posts, not able to cook a meal, finds it difficult to make decisions, not taking care of her appearance, unable to sleep, takes all the messages on group chats personally, believes there is a hidden agenda, fears for her life, asks her husband to report the women who are saying this to her, to report these women to the police, not willing to speak to anyone about it. Again, I know everybody's on mute, but any ideas about Bharat? Anything on the chat?
Paranoia leading to depression.
Okay. That's what's the feedback?
Yeah, that came from the chat.
Okay. I'll move on.
Any other?
Okay.
And tell you the answer. So it's not depression. This is a case of psychosis. So the symptoms that we see in that particular case, I'm just going to go back to that slide. See, if you see, she believes that there are people there who are specifically targeting her, and that is why she fears for her life. So this was actually a patient who she believed that, when she would get a good morning message to say, do good and good things will happen to you, she would believe that there is somebody out there trying to tell her that she doesn't do enough good. So it was a very innocent message, right? We get these kind of messages all the time, correct? But she believed that this was specifically sent by that lady, not to the whole group, although it was addressed to the whole group, but to me, because she thinks that I'm not doing enough good. And there were other such messages where, which you often see. These are the kind of good morning messages that go around. But for every good morning message, she would have this kind of agenda at, that's where it's driven from. So she feared things so much. She would draw the curtain. She didn't want anyone to see what was happening inside the house. And she was so preoccupied by these people trying to cause harm to her that she had forgotten, or she was just not aware of the other things that she had been doing, her cooking, taking care of her husband, taking care of her house, taking care of herself. When I saw her, she was completely disheveled, and she told me, she she said, this is not how I am. And this was before COVID time. So, she came to see me in clinic and she said, this is not how I am, but these people have done this to me. Okay, so this was a case of psychosis. And so let's go into the next slide. So where you have that, again, these kind of symptoms can stem from different mental health conditions. And when we just look at the symptom, we also try to see where is it coming from. So the person who said it could be depression isn't entirely wrong. There are times when it's a depressive condition which is also associated with psychotic symptoms. But there, the quality of the symptom, of the psychotic symptom, is different. So for example, if I am sad, if I am depressed, I think I'm no good. I think, my psychotic symptoms would be like, I think the world would be better off without me. I should do something to end my life. I think, no matter what I do, nothing is ever going to get better. And there would be a very negative flavor to that psychotic symptom, because it's stemming from depression. It's stemming from the fact that I am no good and therefore the world has no need for me. So the nature of the psychotic symptom is important when we try and try and understand where is it coming from. So in this particular case that I talked about, she didn't feel that there was anything wrong with her. She was perfect, and yet there were these people who were trying to point fingers at her and trying to tell her that she should be doing more than what she's doing, and they were looking at how they could make her life more miserable. So there was a very paranoid flavor to her thought process. It could also happen in conditions like Alzheimer's disease and other types of dementia. Again, the kind of psychotic symptoms are different. Particularly during these COVID times, I've had lots of cases where people with mild cognitive impairment, the dementia is not very, very significant. They are very functional people. They've had a bit of memory loss, maybe the usual things. They can't always recall where their glasses are. They couldn't recall, if they have to, if they have a doctor's appointment sometime, they wouldn't remember. So it wasn't too much at all. But over these times, because of the isolation, because of the fear of developing COVID, the fear sets in, and then that has triggered off a lot of psychotic symptoms. So they've started seeing people. There's certainly a few patients who came to me who were seeing people in their garden, and they said, these people are waiting outside. It had nothing to do with COVID. It was just a psychotic symptom on its own. They're looking into my apartment. They're trying to see everything that I am doing. They're making comments about me, and they've fitted the cameras inside my house. So it can go to that extreme too, and completely distressed, not able to sleep at night because they're so worried about these people who are outside. They would also be able to very vividly describe what these people look like, what they're wearing, what they're doing. Because one of my patients was so distressed, he said that person is coming and sitting on my lap. Can you do something to get him off? So it can be very, very scary, and for them it is very real. So I can't have family members telling me this is not happening to them. No, you can't say that, because it is happening to them. And it is not that they're making these things up, but there is a reason. The reason is that they're going through a psychosis, which again is a treatable condition. And if we can treat it, then the distress is no longer there. Okay, so it can also happen as a schizophrenia spectrum. It can happen because of certain medication that could be triggering off. Again, we look at the history and see if there's a correlation between any new medication started and the onset of these symptoms. We make sure that it's not a bad urine tract infection or a chest infection, which can make confusion worse. And sometimes people become psychotic because of that. So it could be, just checking and getting the bloods done and the urine test done. And a lot of times these things can also help to minimize the distress. But as I said, social isolation and sensory deficits, another condition where there is the higher chances of becoming more confused. So we do check and see if vision is intact, if hearing loss is another big one, which I will touch upon later.
Soumya, may I interrupt, please?
Yeah, we're running out of time.
No, not in the least. In my place, I had a power outage and it came back right away. Of course, I have a UPS, so it doesn't affect me. But let me check with other people to see.
Rama's still on.
Rama is on, but can she hear us? Rama? Rama, are you there?
No, she's not, right?
So, can Rama, you can hear me? Is the power situation okay in your house?
Yes.
Okay,
Yes.
yes, thank you. I needed to check that. Soumya, please go ahead. Sorry for that interruption.
Okay. So as I was saying, sensory deficits of any type are extremely important to correct because they could make an existing confusion worse. See, if you're not seeing clearly, there are conditions in which even shadows of the light are misinterpreted as people in the dark. And that is scary. It's very scary for the person who's going through that. And the cause is just a visual problem, which can be corrected. And, we've looked at things like changing the upholstery, changing the nature, don't use patterned curtains, even bed linen, patterned carpets. All these things can, can be misinterpreted to be things that are fearful if it's a visual issue. Hearing, because they can't hear everything clearly, then they misinterpret sounds that they hear in the external environment to be something else, and therefore they put two and two together, and then they become very, very fearful, and that again leads to, and then it escalates because it starts with one small fear and then it keeps escalating till it gets to a point where they're no longer functional. So what is the management of psychosis? One of the most difficult parts of managing psychosis is the person who's going through it often has no insight, often believes that this is all really happening. And, it's not that medication can sort any of this. So it becomes very challenging to give them the help that they need. But it's not impossible. A lot of times we have worked with general practitioners, we have worked with the patient themselves and say that we're not denying anything that's happening to you, but let's at least try and correct some of the distress associated with it. You're not able to sleep at night. Now that needs to be corrected, because even that if you can't sleep at night, you're going to have other medical issues like hypertension, diabetes, which you do not want. So it may not be that your psychosis needs to be treated or anything needs to be done about this, but we can certainly do something about the sleep. So treating the distress associated with the symptom is often a start. And for patients who are non-compliant with medication, it's difficult to give them medication every day. You have other treatment options, things like depot medication, where an injection given once a month is equivalent to a tablet taken every day. So it saves you the trouble of having to go through this, discussion with the person with psychosis every day, because it is difficult for those who have, those who understand what I'm talking about, either have seen family members who have these symptoms or are dealing with it themselves. They know that this is an extremely difficult condition to manage, but if treated, it can be extremely easy to, to work with that person. Life becomes normal again. Okay, so I'm just going to touch upon depression. I know, Mr. Raja, you said not to dwell upon it too much. So I'm just a couple of slides because it's a condition which is, it's very close to my heart. And I feel that this is so often not recognized and not treated. Okay, so often we think that depression cannot happen without any reason. There has to be a reason for depression to happen, but that's so far from the truth. There's so many people who suffer from depression when they have everything going for them. Again, case in point, Sushant Singh Rajput. There's this whole other thing. He was so good. He had everything going for him. What reason did he have to be depressed? And that's often what we hear when celebrities commit suicide. What's the reason for them being depressed? So there is a general perception that to be depressed, something has to be wrong in your life. Others, you can't be depressed. But like any other condition, be it hypertension, diabetes, or any of the other mental illnesses that we've spoken about, anxiety, psychosis, depression, can also result from an imbalance in the neurotransmitters in the brain. It's completely medical and can be treated. So what are the symptoms of depression? So these are symptoms across the age spectrum. So it can be sleep disturbance, either too much or too little. So insomnia in any of the ways that we described earlier, or person just wanting to stay in bed all the time and often sleeping. No interest in activities that they previously enjoyed. So if someone loved to play bridge, or they like to play golf, or they like to read books, watch television serials, now not interested. I can't be bothered. I just rather sit in the dark. Guilt or feeling worthless, feeling that life has no meaning, there's no point in carrying on. What's the purpose of my life? Energy, no energy to do anything, always feeling tired, difficulty in concentration, appetite appetite disturbance, either they find that there is no taste, they just don't appreciate any kind of food, or they start comfort eating. So they're eating a lot of food which they shouldn't. It's unhealthy food. Psychomotor agitation or retardation. So they're very sluggish, very slow. Speech becomes very slow. Their level of, the way they walk becomes very slow. They just don't have the energy to carry themselves, or they're agitated, very restless, when you have restlessness associated with anxiety, with depression. And in extreme cases, they also have suicidal ideation and thoughts of just wanting to end it all. And we often ask about this. Again, there's a misconception that asking about it might make the person think about it, but I think it is, there's enough evidence to suggest that you need to ask, because if you've not asked, you've missed that opportunity to help that person. So those were the symptoms that were across the age spectrum. Now, if we look at the older population, specifically symptoms of depression in an older population would be slightly different from a younger population. So the older people would not feel, they would again assume that I'm getting old and therefore I'm getting weak. I'm getting old and therefore it is natural for me to feel more tired. And therefore they would not understand, or they would not assume that there is something wrong. What they would often complain about: persistent and vague, unexplained physical symptoms like a backache or a gut problem or a chest infection or a cough that doesn't seem to have any kind of physical cause. All the investigations and tests would have been done, lots of medications tried, multiple second opinions, but doesn't seem to be going away. And they become very preoccupied with that physical symptom. Anxiety and agitation can go along with depression. Memory problems. So because they're finding it difficult to concentrate, they can't remember. So again, it is not primarily a memory problem, but it is a concentration issue, which looks like a memory problem. So many times I've had patients brought to me with a diagnosis of dementia, but when you actually look at where the memory problems are, why are they having the memory problems, it turns out that it isn't a memory issue. It is a fact, they're not concentrating. They're sitting amongst people and their mind is somewhere else. So they're not listening to the conversation. So when I ask them what is discussed, they can't remember because they just haven't paid attention. Not because they have paid attention and they just can't recall because of a memory deficit. So it's important to distinguish between the two. Socially withdrawn. A lot of elderly people feel, nobody wants to talk to me. I don't have anything interesting to say. Why should I come in the middle of all these young people? I'm better off sitting by myself far away. So, as you see this elderly person who previously had a lot to contribute to the family, slowly starting to withdraw, that is also an indication of depression. A high degree of suspicion and specific inquiry is necessary for its detection and treatment. I say this because it is often overlooked. As I said earlier, very, very often elderly people are, just 1 minute. Can you hear me all right?
Yes.
Yes? Okay. So very often, doctors would only be looking at the physical symptoms and giving them more and more medication, which could actually make the condition worse, when actually what they need to do is just treat the depression, and a lot of the other problems will automatically take care of themselves. So you'd be probably treating them for high blood pressure, diabetes going up because the person is so stressed and worked up and not able to sleep. You treat the depression, all these other conditions get better, and the medication levels of medication come down. So the interventions, as I said, there are medications. There is also psychotherapy, where talking to somebody, because you do try and talk about what is it that you're worried about, what is it that bothers you, why is it that you feel you should no longer be a part of the family gatherings. So there are times when just talking about these things can help a person get them back on track. But if it doesn't, then we have to resort to medication as well. A combination of the two works perfectly. So then we don't have to use too large doses of medication, small doses of medication and psychotherapy on a regular basis. But there are cases where we've tried multiple medications. Either the person is not able to tolerate the medications, multiple adverse effects because of the tablets, and the condition is not getting better. They are suicidal. In those cases, electroconvulsive therapy, which was previously called shock treatment, which we don't like to call it that anymore because it just gives this very, very negative connotation to an extremely effective form of therapy, which is electroconvulsive therapy. And particularly in the elderly, with the minimum amount of adverse effects, it has helped to treat a lot of people with very severe depression. So again, a condition, a kind of treatment which has a lot of myths associated with it, but it is an extremely effective mode of treatment when all else has failed. Moving on to the next one, happy hours. Okay, so again, I'm just going to touch upon this. I'm not really sure how relevant it is to this audience, but it is a condition that we often overlook again. Okay, so it's the one last pleasure. It's often called the one last pleasure. So I'm talking about alcohol use. What I'm talking about is harmful alcohol use, okay? Not the 2 pegs every day or 2 smalls every day, that's fine. So this is harmful alcohol use, much more than the 2 smalls. So though harmful alcohol use can have serious medical problems, you could result in stroke, impaired motor skills, your hand-eye coordination, your fine motor skills could be impaired if you're drinking excessively, injuries because you might have falls, sleep disorders, which I touched upon previously. You might fall asleep, but you won't be able to stay asleep. Suicide, again, because it kind of triggers off a lot of depressive symptoms, negative emotions, people who drink constantly, and then you go into this vicious cycle again. I don't want to feel like this, so I drink some more. The minute I become sober, I start feeling like this, and therefore I drink some more so that I don't feel like this. So depression and suicide are often coexisting with excessive alcohol use. And interaction with dementia symptoms. So if someone has mild dementia, mild cognitive impairment, and they're drinking large quantities of alcohol, the level of confusion becomes a lot worse, and the level of functioning is quite impaired. So again, it is important to check in the history when we do check and see if there is alcohol consumption and how much is the alcohol consumption. So moving on to how much. So this is kind of a standard tool that is used. So each of you can see, if you do drink, where you stand on the scale, how much of whatever is your favorite, your preferred poison. And that's from the UK, where they recommend 14 units per week. It used to be 14 for women and 21 for men, but I think the revised ones just says 14 units across age groups. But again, most of these studies are done in a younger population. So this is 14 units for a young adult, not so much for those over 50. But 6 pints of 4% beer per week, or 6 glasses of 13% wine, or 14 glasses of a 40% vodka shot is fine. So I think that's more than enough in most cases. So there's a condition which is called late onset alcoholism. So these are people who become alcoholic or start, tending to use large quantities of alcohol for the first time late in life. So that's where we often miss it, because they might be drinking their 2 smalls all their life, but the children wouldn't notice that the 2 smalls have become 3 larges and then 4, and then there's a bit of mid-afternoon drinking, there's a bit of early morning drinking. So, it's often missed because the person had been drinking all his life. But when it starts becoming more, it's missed. So it's often triggered by a stressful life event, or again, social isolation. The milder cases with fewer comorbidities, as opposed to people who have been drinking large quantities of alcohol throughout their life, the ones who start drinking later are less likely to have conditions like liver cirrhosis or kidney damage because of alcohol. So it's mostly milder in terms of medical issues, but there are a lot of psychological issues associated with late onset of alcoholism. They are more amenable to treatment because it isn't a lifelong condition that has been not treated. But they're more likely to be overlooked by healthcare professionals as well as families, because they've always had bottles of alcohol at home and they've been fine. So why should we assume that now they're not? Okay, so the treatment is slightly different when it comes to an older population. We are more supportive. We understand why they must have resorted to drinking alcohol, and therefore we're not going to get on and say just quit and just stop. You need to stop today. No, it's not going to be a very confrontative kind of a treatment. It's going to be more supportive in terms of trying to help them with whatever the underlying issues are, whether it's depression, loneliness, or overcoming loss, often bereavement. So we look at those issues and manage that, and that's how the alcohol consumption can also come down. Teach them skills to rebuild their social support network if it's social isolation, and a culture of respect. I mean, people who are, elders who drink should not just be, oh, he just drinks the whole day. I mean, that kind of culture doesn't help, because it isn't helping the person, get the support that they need. So I think we need to develop a culture of respect, that they are drinking for a reason, and let's try and help and support them find out why they've resorted to alcohol. And if you can't help them, get them the help that they need from professionals. Okay, so that was about alcoholism. Now, the question that I was also asked to address today is, can the onset of cognitive impairment be delayed, or can we try and keep ourselves safe from developing mental illnesses as we grow older, be it insomnia, anxiety, depression, or psychosis? What do we need to do in terms of life practices so that we do not succumb to these conditions, or even if we do, then they're not as severe as to cause major dysfunctions and disruptions in our life. Okay, so there's this concept of a cognitive reserve, which has been spoken about quite a lot over the last decade and more. It's the studies coming out from 2008. So cognitive reserve, I'm just going to read this out and then explain it to you. It is the ability of our brain to resist the effects of disease by modifying life course experiences. Those with a higher cognitive reserve tend to have better clinical outcomes from any level of pathology. So we will talk about how to build the cognitive reserve, but essentially those who have a higher cognitive reserve, if they have a stroke, if they have depression, if they have anxiety, if they have any issues related to mental or physical health, are able to cope with that condition better, are able to have better outcomes, they're able to recover better because they have a better cognitive reserve, as opposed to someone who does not. So the same stroke, two people, one who has worked on their cognitive reserve and the other who has not, better outcome in those who have a higher cognitive reserve. I hope I've made myself clear in explaining that to you. So so this was, one of the study just came out very, very recently. August 1st week was published in the Lancet, and this is big work and a big message that it's never too early and never too late in life for dementia prevention or for prevention of any of the conditions, because we have had lots of studies done which say that the onset of these conditions starts way before we actually start seeing the clinical signs. So if we see a person with dementia in their 70s, the brain had started showing changes way back in their 30s and 40s, but we had no way of knowing it. So what differentiates someone who had the brain changes at age 40 from showing symptoms at age 70 or age 90? So why do some people who have the brain changes not show the symptoms of dementia right until their 80s? And why do some people who have the changes start showing symptoms in their 60s? So that's to do with cognitive reserve. That's to do with how do we push the symptoms another 20 years, if possible, by doing the right kind of stuff. So even though our brain has started changing physically and psychologically and to the external world and to ourselves, we haven't changed. Okay, so this is a pictorial representation of what the study showed. And as you can see, there are these various conditions and there are numbers next to them. So as I was telling you earlier, that hearing loss contributes to 8%. Now we're talking about dementia here, okay? Cognitive impairment. It is impairment of functioning as we grow older in all aspects, not just in one aspect of memory, but dementia covers multiple aspects of our thinking and functioning. So hearing loss has an 8% contributing potential. So if you correct your hearing problems, if you make sure that you test your hearing on a regular basis, along with all the other blood checks that we do as we hit 40, we start going in for comprehensive health checks. We do an ultrasound, we do the treadmill, we do all our basic bloods, but not many people get their hearing tested, or rather assume it to be a function of aging and nothing can be done. But hearing loss can contribute significantly to worsening of cognitive symptoms. So correcting it, wearing the right kind of hearing aid at the earliest is definitely very, very beneficial. Traumatic brain injuries like falls or riding without helmets can cause about a 3%. If you protect your brain from traumatic brain injury, you're protecting yourself 3% chances of getting dementia. Hypertension, alcohol, more than 21 units per week. So given us some leeway here. So it's 21 units in this study, not 14. Obesity, particularly, your mid-obesity in midlife is the way to look at it. So if you've been slim and trim and then suddenly you hit your 40s and 50s and start to put on weight, that's where it's more worrying. And, you tend to avoid, you should try and avoid that. So avoid that sedentary way of life where you start putting on weight around your middle. Smoking contributes 5%. And every year that you quit smoking adds to your lifespan and in a productive manner. So smoking is dangerous. Smoking affects not only your lungs, but also your brain. So, try and quit smoking or minimize at the earliest. Depression, social isolation, physical inactivity, air pollution has also been added to this list recently. I think it's because a lot of studies coming out from metropolitan cities where we are, facing large levels of air pollution. Diabetes. So as you can see, the two circles at the right of the bottom of the slide, 40% of these causative factors are modifiable. We have some control over them. 60% have factors are unknown. We're probably born with them, they're genetic, we have no control over them. But the remaining 40% is controllable. That's almost, it's close to 50. So it's giving us a 50% chance of controlling what the rest of our life is going to be like and whether we can try and prevent or push dementia or the onset of dementia as much as possible. So again, just presenting it in a slightly different way. So you've got the modifiable risk factors. Those are the 40% of risk factors. So if you see what increases risk, things like traumatic brain injury or hypertension, diabetes, smoking, history of depression, sleep disturbances, and hyperlipidemia increases the risk. Good education, years of formal education. The more educated you are, the more protected you are. Physical activity, a Mediterranean diet, or I would say, because most studies are from abroad, but in our case, I think, a healthy, balanced diet, not too much of anything. Cognitive training, keep your mind and brain active, learn new stuff. Bharat was telling me yesterday that, he does so much complex mathematics, that should be enough. And, mathematics is a very complex subject, but it's not about doing the same thing in a more challenging fashion. It's about learning new things to do and then increasing the complexity of those tasks that matter. So I always give this example is that, if you're a teacher and you've retired as a teacher, don't spend the rest of your life giving free tuitions. That is not going to help your brain. You might be, socially very, very contributing to society by giving free classes, but it's not helping your brain. Try and learn something new. So if you're a banker, move into learning Sanskrit or learning something completely different or playing a musical instrument. If you've never set foot in the kitchen, try to go into the kitchen and learn to cook, but do something completely different. That fires more neurons in our brain, and that keeps our brain active for longer. And that's building cognitive reserve. That is what happens when you build cognitive reserve. And if you've done all this and then you have a stroke, your outcomes are going to be way better than someone who's not done these things and then suffered a stroke. So moderate alcohol consumption and social engagement. So those are all protective to our brain. So here's just talking about some of the other stuff which was not mentioned, physical exercise, and just to show you what happens with just 20 minutes of a walk. You can see how our brain fires up, how many areas of our brain light up, because you're doing so many things when you go for a walk rather than sitting in your house quietly. You're smelling different things, you're hearing different sounds, you're seeing different visions. You probably say hi and hello to 10 more people, and you recollect who they are, what their names are, and which apartment they live in, which is all cognitive activity which you wouldn't do if you were sitting inside your house. So that's just a 20-minute walk, not even a brisk walk. Also about negative energy and positive energy, this is the spiritual side of things. Try and stay away from things that don't make you feel good, people who don't make you feel good, news items that don't make you feel good, WhatsApp groups that send you information that you don't want to know about and create anxiety. So make a serious attempt to cut those negative influences from your life and focus more on the positive side of things. Focus more on doing something that gives you more happiness and fulfillment. And this is something that I always feel is one of the the best ways to keep our brain active is to find a purpose. If we have a reason to wake up in the morning, we're sorted. It's a lot of times I have people who would be in their 80s. Recently I saw an 85-year-old. So this is the example I can think of right now. An 85-year-old who took care of her ailing husband for 10 years before he passed away. Extremely active, in spite of taking care of him, would be connected to her relatives, would, do everything that was necessary, cook all these different special meals when her children visited, keep in touch with the grandchildren, extremely vivacious. And once he passed away, we saw the downside. We saw her slowly getting worse, and it all came down to the fact that she had no purpose to live after that. And you need to find a purpose to life. There has to be something that still makes you go on, because if you start telling yourself that there is really no reason for me to live, and it doesn't matter whether I do this or not, then you are asking for trouble in terms of allowing your mind to start rusting before it needs to. So finding a reason to wake up in the morning is extremely important. So summing it up, if we look at what are the various things that, and what are the risk contribution. So of course, if we keep ourselves physically active, it's, almost 41% risk reduction, cognitively active, 44% risk reduction. But if you keep ourselves socially well connected, that seems to be the most beneficial thing for our brain. Keeping, so this whole social distancing has not done well. A lot of mild cognitive problems have worsened because of the social distancing. So it's very, very important to keep our social engagements. And, going back to what I said earlier about COVID anxiety, if the risk of COVID is not as much as, the benefit of going out and keeping myself mentally well, then I would go out, wear a mask, and keep the physical distancing and interact, and at least talk to people, see somebody's face and not see them all virtually all the time. Okay, so that's the last slide. Thank you. And as you can see, there's lots of thank you said in many, many different languages, because that's also a lot of studies being done on bilingualism and multilingualism and how that's protective for our brain. And it's not, and being from India, all of us speak a minimum of 2 languages, if not more. And, it's protective for our brain. We're naturally protected because of the environments that we live in. But what is important is to keep shifting between the languages, apparently, to protect our brain, not just being aware of multiple languages. So you can see, that our maids are very protected because they'd go to Mr. A's house and speak in Tamil, and go to Mr. B's house and speak in Kannada, and then the next house in Hindi. So they're doing a lot of this, shifting from one language to the other multiple times in a day. And it must be brilliant exercise for their brain. But they need to continue doing it as they get older too. So with that, I think I've kept a little bit over time, but yeah, thank you very much.
Yeah, thank you, Soumya. That was excellent talk, and already I'm hearing a lot of people on the chat board expressing the same emotion. It was wonderful. From a point of view of efficiency, it'd be easier for me to ask a couple of questions that have come on the board. And then if we have time, I'll open it to the audience for live questioning. So one of the things was, I'm sure you get asked this, I think it's an important one.
Should I stop share, Bharat? Can I stop?
Yeah,
Yeah,
sure.
I think.
Yeah, then I can see
Yeah.
more people. Yeah,
That's
okay.
Right. Okay. So she's asking, forgetting of immediate things like putting milk to boil and forgetting, is that a symptom for beginning dementia?
Okay. I boil the milk over all the time. I keep forgetting. Even today, I burnt my dal. But the thing is that, if you forget that you've left the milk on the gas, but you come back to the kitchen and you remember, then that's fine. If you have come back to the kitchen and you don't even remember keeping the milk to boil, or you think somebody else has done it and not told you about it, then that can be a symptom of dementia. So as long as you're able to trace your steps backwards, you're fine. So there are times when like this morning, I put my sugar in the microwave. I was trying to do 100 different things. So I put sugar in my coffee, and I wanted my coffee a little warmer, but instead of putting the coffee mug into the microwave, I put the sugar container into the microwave. And I was like, where's the sugar gone? So but I remembered, right? So I remembered that why it had gone there, because I was trying to do 10 other things at the same time, and that's what had happened. So as long as you're able to retrace your steps, as long as you're able to tell yourself, oh, that's how it landed up in the microwave, and this is what happened, then you're fine. So by itself, it's not a symptom of dementia. What is important for us is to understand whether you remember when you had done it and if you had done it at all.
Thank you. One more from the chat board. Are there any food types that should be avoided for anxiety, or any food that we should take to improve our minds more generally?
Okay. For anxiety, I think I could say not what to take, but what to avoid. So certainly avoid junk food, foods rich in carbohydrates and sugars, because when people are anxious or depressed, we tend to snack on these because we feel better doing that. We feel comfortable doing that, and that can cause more health-related problems. So I would say avoid these foods and just stick to your normal regular diet. Have your 3 meals, proportioned meals a day. High protein is always good. Less fat, and the timings of the meals, avoid having these multiple snacks through the day. Try and stick to your meal timings. That would be the advice for anxiety. In terms of cognition, this again, post the Lancet study, there's also some other studies that are associated with it, which say that glutathione rich foods, and this is something that even I'm just learning about, but so I'm not going to shout too much about it, but this is what is recommended: is glutathione rich foods, things like broccoli, your cabbage, pak choy. These foods are supposedly very rich in this substance called glutathione, and therefore is good for your brain. But generally, I feel that eating lots of fresh fruits and vegetables and avoiding junk food is good for our brain. And keep the variety, the sprouts and stuff like that is always good. So
One
avoid
more
too
thing.
much of anything.
Thank you. One more from the board, actually. It's actually stated just as a statement, but I think there's a question here. I'll frame it as a question. So is a person who finds it difficult to trust people due to deep-rooted negative experiences from young age, from near ones, is such a person more prone to psychosis or more generally mental illnesses?
Again, it depends on their level of social interaction now. So if the deep-rooted sense of fear does not allow them to engage with people at all, then it's contributing to, it's the causative factor would be social isolation as they get older. And therefore, the chances of a cognitive impairment or a psychosis or the fear building on would be higher. So it's about, you don't have to, like you've joined the Zoom meeting. You don't have to trust all the people here, but you're still connected in some way to a lot of people whom you do not even have to see physically or meet with them or know anything more about them than the name that is displayed on the screen. So what I would say to this person is, as long as they are socially connected and not dysfunctional as a result of their inner fears, they don't have much to worry about. But if as a result of their fears, they are not connected socially and they are spending more and more time by themselves and in withdrawal, then yes, there is a higher chance of them succumbing to one of the mental illnesses. It could be an anxiety or anything. It could be as, as mild as an anxiety going on to as something as significant as a psychosis or dementia.
Thank you. So what I'm going to do is I'm going to open it up for another 5 to maybe maximum 10 minutes for the audience. I'm going to allow people to unmute, but I would request most people do not unmute yourselves. The one who wants to ask a question, go ahead, unmute yourself and ask a question. But for others, please stay unmuted. But right now, right. I believe anybody who wants to ask a question can unmute themselves.
Yeah, may I start with the question?
You can start with the answer to the question that was already asked to you.
That one. Yes, that was from my very close friend, Mr. Tulsi Tiwari. He says that I am a learner and that I don't show signs of anxiety. The second part is not quite true. But I would present myself more as a patient than as a learner when I see someone like you in front of me, because a lot of the things that you have talked about, we can immediately relate to, and I can relate to. And one of the questions that I have is, and this may be true of a large number of persons who move into the 80s and 90s.
Is there any cure?
Can you hear me?
Yeah, we can, but I think too many people have their microphones on.
Oh, okay.
Go ahead.
You talked about psychological age, which I think is very true in the case of many of us who are in the 80s and 90s. In fact, the average age in Athashri is around 80. Could it be that a person, feels that psychologically till the age of 80 or so, he's psychologically, let's say, 70 or 65. And then suddenly, when he's 82, he feels he's 87. And because he moves into a much more of a retired life, much less active. And if that happens, can he come back to 70 or 75?
Like the 102 not out. I think you're right. You're right. And this is something that we have seen very often, and not just moving into a retirement facility. I have seen this happening so often when parents move in with their children. This I have seen in practice very, very often. I'd have this couple who live in a small town somewhere in India and had their life was going on. The husband would go get his groceries, and not a day that he thought that I'm aging, because the routine was the same. He had been doing these things for 30, 40 years. There was no reason to think any different. And then there must have been, a physical illness of some sort. Maybe, the one of them was diagnosed with diabetes or hypertension or a cardiac condition, and the children said, look, we can't keep coming and going. It's very hard for us. You need to shift closer to where we are so it's easier, and there's not many medical facilities here. You need to come into a big city like ours where there's lots of medical facilities. And that's when the 82-year-old suddenly starts feeling like an 89-year-old. So I think those are the conditions I have seen where, nothing's changed, but overnight they suddenly feel aged. Because from a whole house, they've moved into a small little room. That was one of the reasons that they gave. And they don't have the freedom. They've lost their friends and everything else that went with making them psychologically younger. The second part of your question was, what do you do? Can they revert back to feeling how they were? And I think that's where the treatment that I mentioned earlier, the psychotherapy, the cognitive therapy, can play a role, because it's not a clinical depression, but it's just a shift in their entire mindset, right? It's a very different way of thinking, where they suddenly think that ab kya karna hai? up to, there's really nothing more in my life. Now it's just about dropping my grandchild to the bus stop and coming back. Yes, but then they do tell you that, no, it's not that I don't enjoy being with my children. I mean, I love the fact that I can see my grandkids every day, but it's not the same. But I miss something about my life where it was. And so again, looking at how we can connect them to more people is what we try and do, getting them to look at, okay, let's try and resume some of those activities. Don't give up. And there are a lot of times when I've sent people back to their small towns and I've told the children that this is just not going to work in a city like here. It's okay. As long as they're alive, at least they're happy. So there are times when we've just had to do those kind of things, get them back. So it can be a mindset shift. It could be, somewhere in your head you have assumed that, up till the age of 80, this is, I can do what I want, but come 85, I should stop doing this, that, and the other. So if you've set these benchmarks in your mind, then it becomes hard. But you should not, there are people who tell me that on my 80th birthday, I will stop driving. Array, you should stop driving when you're no longer able to drive. It shouldn't be your age deciding that. Or, when I'm 85, then I will do this. No, it's not about decide. I think our physical state and our mental state should decide what we do and what we don't do, and not the age. So that's what I meant by psychological age.
Thank you very much.
Thank you. I know many of us would just love to go on, but there are reasons to stop, and I think we really should stop. It's close on to 6. So thank you again, Soumya. Mr. Raja, can I request you to please say a few words?
Yeah. Thank you, Soumya. Thank you very much. I'm so glad you chose the subject that you did choose, because you covered depression all right, but then we wanted you to cover much more than that. And when you covered every one of the things that you spoke about, we could relate to. And we as a community in Arthastri have gone through many of these experiences. Fortunately, we are a community, and to the extent possible, we're able to organize community support for those who might feel lonely, who might even face the prospect of social withdrawal. The other thing that we particularly liked about your talk was, your emphasis on, you're talking about social distancing, and your emphasis on what perhaps is not social distancing, but physical or spatial distancing more than social distancing. And in these times, I would think, as you very correctly pointed out, that we need more of social bonding and not less, and perhaps more of physical distancing. That's one of the points that particularly struck us. And the coverage was so vast, so enlightening and instructive, as the feedback has been coming from most of our members, that we would like to share this with a wider audience, with all the other Arthastris, and with other senior citizens that we know in our neighborhood and outside, who would, I'm sure, benefit immensely from what you have said. I am also grateful to you for having talked not merely about the different mental aging problems that we face, but the solutions, both physical and mental, that we can resort to. And that's something which is of great value to us. We have therefore been immensely enriched by what you have said. Thank you very much indeed. You've given us much more to look forward to. And as you said, search for a meaningful life, which is what keeps one going. And that's what we are basically looking for. Thank you very much indeed. On behalf of all of us at Arthastri, come again.
Thank you. Thank you, all the Arthastri members. It's such a it's even I get fed up of just doing online consultations, and I miss the social connect too. So we try and do as much as we can, but it's so nice. I see so many familiar faces on the videos. Hi, Mrs. Geeta. And
Hi.
so it's really nice to see Athashri members, because you guys you are a fantastic community, and you do so much for each other. And as you rightly said, Mr. Raja, I think you all have taken it upon yourselves to make sure that at least every member of the Athashri community gets the support that they need when it is needed. And that's all that matters. I mean, at the end of the day, we can't expect a lot from the world, but we can expect it from our neighbors. And it's so nice to be a part of this community whenever I get the opportunity to do that. Thank you for the invitation.
Thank you
It's a
very
pleasure
much.
being with all of you all.
Thank you.
Thank you, Rama. Thank you, Bharat.
Thank
Bye.
you.
Bye, everybody.
So we'll be in touch. A lot of people on the chat also are just pouring in their thanks to you.
But
thank you all. Thank you.
Yeah,
I really
yeah,
appreciate it. I learned so much from all of you. So thank you. Thank you very much.
I will end the meeting for everybody.
Okay.
Bye, everybody.
Bye.
Yeah.
Bye.